just mic checking. We've already done the mic check, and now we just want to introduce the topic. We'll be looking at comprehensive management of HIV in adolescents and young people. Like I said before, if you are able to share this link to others, please do, so that they can be able to join. Sorry about that. Good afternoon. We were just doing last-minute IT checks. So welcome to today's echo session. My name is Malidwe Muhuma. I am an HIV/TB medical officer under the Lusaka Provincial Health Office. If you can't hear me, you can just let me know. Sometimes we may have a network failure. But I'd like to warmly welcome all of you that have joined. So far, we have over 70 connections, and we encourage that you can share this link so that more people join. Remember, when people join, you look into the chat box, you will find there's a registration link, and you'll be able to register your participation in this session. So, as I said, we're looking at comprehensive management of HIV in adolescents and young people. And the didactic session will be done by Dr. Chalilwe Chungu, and then we will go into a session of some questions, answers, and then we will have a case from Chadiza District Hospital. They have a very interesting case, and we'll be able to discuss now. So, remember to mute your mics when you are not talking, so that we don't disturb the flow of the meeting. That is part of echo etiquette. We will try to do this in good time. I know this is a very interesting topic. So we will have some experts on the call. And I'd like to check if we have them now at this point. Do we have Dr. Muya on the call? Dr. Lugano Nkoma. Esnat Nsato. Do we have Esnat on the call? Please say hello to the network. Dr. Mando Piri, do we have Dr. Mando Piri on the call?
Yes, I am. I'm on the call. Good afternoon.
Good afternoon. Thank you. Thank you for joining us. So I will request that as the presentation begins, the experts can look into the chat box. I'm sure there'll be some questions that will be coming. So we'd prefer it and would like it if some of the experts would attend to some of the questions that will be coming in through the chat, so that we move together along. But at the end of the presentation, Dr. Chalilwe Chungu will take us through some of the queries that we might have. So at the end of the session, remember, when you want to ask a question, you can either raise your hand or you can type it in the chat box and we will get to you. As a reminder, the registration link has been shared in the chat box and will be shared periodically by the IT team. They'll be the ones controlling things, and please remember to log in your participation. We also have Dr. Ziambo Kozia as one of the other experts that is supporting this session. Here at the hub, I have 2 IT personnel that are helping to run things smoothly. So at this point, after the introductions have been made, I'd like to invite Dr. Chandile Chungu to take us through the didactic presentation. Dr. Chungu, will you be able to share from your end?
Can you see my slide sets?
Yes, we can. Thank you so much.
Okay. All right. Okay, thank you, and good afternoon, Dr. Malirwe, and good afternoon to the network. So I will be sharing today's didactic, which is on management of adolescents and young people living with HIV. My name is Dr. Chungu from the Zambia Pediatric Association. I have no disclosures. So,
Dr. Chungu,
yes.
sorry, are you able to put the presentation in slide mode? Okay, great.
Okay, thank you. Apologies for that. So I'll take you through the objectives. We'll look at some key definitions, and then we'll look at the epidemiology of adolescent HIV, and then we'll see adolescents as a distinct group of those affected with HIV. And then we'll also look at why is it that adolescents are at increased risk of acquiring HIV. We'll look at what the package of care for adolescents looks like in Zambia, as well as prevention services and how to optimize treatment effectiveness and support adherence for those who are living with HIV. And then, of course, very important with adolescent HIV is the issue of transitioning them to adult care in a smooth way. And then how do we support their long-term care after they have transitioned? So our objectives for this afternoon is to look at the epidemiology of adolescent HIV in Zambia and globally. What are the characteristics of adolescents? And then we also will look at optimizing treatment effectiveness and how to support adherence in adolescents and young people. And then we'll also look at challenges they face and discuss strategies for successful transitioning. So some key definitions, according to the World Health Organization, a child is anyone under the age of 18. I know that it sort of gets confused because usually in our health services, we have a cutoff of 16. And so we've run into sometimes with definitions, even with the Child Rights Act, which defines it as 18 in line with WHO. And then adolescents are individuals aged 10 to 19. And then youth are aged 15 to 24. And then young people, individuals aged 10 to 24. Apologies. So globally, approximately 5 million young people aged 15 to 25 live with HIV. According to our Zambia Demographic Health Survey, the prevalence among adolescents and young persons is 3.8%, with prevalence higher in young females at 5.6% in comparison to males who are afflicted by 1.6%. The health survey showed us that there were low levels of comprehensive knowledge among adolescents. And so there's a set of questions that they're asked in the survey that assesses their knowledge levels. Particularly concerning is the age of sexual debut, which shows that at 15 years, some adolescents have already engaged in sexual activity. And there's also low condom use reported among adolescents at 33%. So this puts adolescents at higher risk of acquiring HIV as well as sexual transmitted infection, teen pregnancies, and high school dropout. So with that background, I'll hand us over to our moderator to take us through for question 1. Over to you.
Okay, thank you so much. That's a really fitting introduction. This is really going to be a great session. For question number 1, 10-year-old Manzi, this is a sort of a scenario question. 10-year-old Manzi presented to the health facility with multidermatomal herpes zoster on his back. An HIV test done, comes out positive. His mother died 8 years ago. The following are possibilities of how he could have most likely acquired HIV, except A, at birth from his mother, or B, breastfeeding, C, sexual activities, D, sclarification marks made on his body by his grandmother for chronic diarrhea. That's our first poll question. We have a minute to poll. So can we get polling? 10-year-old Manzi presented to the health facility with multidermatomal herpes zoster on his back. An HIV test done, comes out positive. Okay, his mother died 8 years ago. This is a 10-year-old whose mother died eight years ago. The following are possibilities of how he could have most likely acquired HIV. Is it at birth from his mother? Is it through breastfeeding? Is it through sexual activity? Or sclarification marks made on his body by his grandmother for chronic diarrhea? So which of these methods is not likely for him to have acquired HIV? So out of 220, we only have about 30% that have polled. We'll give it another 15 seconds. Is it that many of us are unsure? Just 10 more seconds. Okay, we'll end the poll here and we'll share the results.
Okay, can we continue?
Okay, from the poll, as you can see, about the majority actually think, 40% think that sexual activity is the answer. So we'll hear from Dr. Chalilwe Chungu as he goes through the presentation. Thank you.
Okay, thank you, Dr. Marilwe. And I mean, let's discuss this. I think a lot of times in medicine, we always have these, controversial discussions. So we have two distinct groups of adolescents who are living with HIV. There are those who get it perinatally in early childhood, like for example, from their mothers. And then there are those who get HIV during adolescence, like for example, through sexual activity. And we'll look at this and also look at how that impacted our answer. So adolescents who acquire HIV from their mothers usually get it from mother-to-child transmission, and usually they would have been enrolled in care earlier. Of course, I'm sure a lot of us have come across those who present later, who are, small for age, with a lot of skin stigmata and other issues. That those identified later during an acute illness or during routine testing. And then many of those who get infected with HIV around birth have been missed by the healthcare system. And you'll all agree with me that that is the reason why we're having such sessions, so that we can have holistic services for adolescents. And so many have initiated ART in infancy and taken various regimens by the time they reach adolescence. And just like the case we'll have later on, we'll see that sometimes you can see adolescents with very complex treatment histories. And that's very important as we are formulating a plan in addition to adherence. So Some of them may not even have been fully disclosed to. I'm sure those of us who are looking after adolescents come across this scenario very often of adolescents that, haven't been disclosed to, or accidental disclosure by a healthcare worker, depending on their age and caregiver. And that's even if the primary caregiver is still the biological parents, because sometimes you find that they're deceased as well. So those who acquire HIV during childhood or adolescence could have acquired it through consensual sex. I don't know how consensual sex can be between an adult and an adolescent. Sexual abuse, or less frequently through blood transfusion or sharing, cutting or piercing instruments or injecting drugs. Or they may have recently learned of their status identified via HIV testing services, or they may just be asymptomatic. I'll hand over to Dr. Malilwe for poll question number 2. Over.
Okay, thank you, Dr. Chalilwe, for that. So I can see Dr. Wupe Musonda is also on the call, and we'll treat her as an expert for this session. In the chat, she's already said that sexual debut has actually been recorded as low as 10 years old. So just something to take note. So for question number 2, the following factors put adolescent females at risk of acquiring HIV. Okay, the following factors put adolescent females at risk of acquiring HIV, except A, insufficient thickness of the vaginal wall, B, insufficient mucus protection, C, they do not know how to clean their genital area, D, cervical cells, which are the columnar epithelium, which are protective against infection, are not yet fully developed. We can launch the poll question so that people can start polling. For those that may not be aware, we do a re-poll after the session is, after this didactic presentation is done, so that we go through the answers. So for those asking what the answers are, just kindly hold on. Question number 2, we can start polling. The following factors put adolescent females at risk of acquiring HIV, except insufficient thickness of the vaginal wall, insufficient mucus protection, they do not know how to clean their genital area properly, or D, cervical cells which are protective against infection are not yet fully developed. We have 30 seconds to poll. We'll give it 10 more seconds. So we'll end the poll here. Thank you. About over 60% have polled. We'll share the results. So we find that the majority, 69% of those that polled, think that C is the answer. So we'll continue with the presentation. Thank you.
Thank you, Dr. Malilwe. So why adolescents at higher risk of developing HIV infection? So adolescents are in the middle, they've got an immature genital tract, and so they're more vulnerable to STIs and HIV due to insufficient thickness of the vaginal wall, insufficient mucus protection, and then their cervical cells, which are protective against infection, are not yet fully developed. So just like in our context, also social and cultural environments are very strong determinants of social risk-taking. So you find that in some provinces in Zambia, for example, girls get initiated into early marriages. And sometimes their parents are actually behind that. So you can see the role of culture and our socialization coming into play as well. And then poverty and isolation increase, and adolescents likelihood of becoming sexually active. There have been several studies in Africa, here included also, that found a significant percentage of girls aged 11 to 15 had either had a baby, an abortion, or were pregnant. Because when a woman is empowered, it encourages her to, further her career path. And that's the basis of programs such as Dreams, where, it encourages women to be determined, resilient, empowered, mentored, safe. And so some challenges faced by adolescents, just like we said from the demographic health survey, limited knowledge on prevention, transmission, limited access to health information and care, lack of adolescent-friendly health facilities. This is particularly concerning because we keep talking about it, but when we actually go and see how friendly adolescent services are, we are lacking in that regard. And also myths and misconceptions on sex and sexuality. I'm sure some of us on the network will recall, we might have heard about sex from a peer, and it could have been distorted and not presented the way that it is. Issues of marriage, childbearing, cultural sexual roles and expectations, disclosure, poverty, transactional sex, sugar daddies, sugar mummies, blessers, growing up in dysfunctional families. Several studies have shown that people who don't grow up in a functional home actually have developmental issues later in life. Peer influences, stigma, discrimination, as well as adolescents engaging in activities without analyzing the consequences. So there's a study that was actually done that showed that the limbic system in adolescents is similar to that of an infant. Usually infants will take very high risk behaviors without looking at the perception of it. So their risk perception is lower than usual. And then if, like I said, if you've ever looked after an adolescent with HIV, adherence will always pop up. And that's because of issues to deal with denial and fear of HIV infection, misinformation, distrust of the medical establishment. And that's why we have a lot of work to do as healthcare workers to ensure that we build the trust of our adolescents. Also, fear and lack of belief in the effectiveness of medications, low self-esteem, unstructured and chaotic lifestyles. I remember this one adolescent who was always moving between homes, had multiple mothers, and so was, different caregivers, and all that lack of structure is predisposing towards poor adherence, which consequently would result in lack of family and social support. So what are some of the challenges that we face in addressing the needs of adolescents? So from the caregiver perspective, some caregivers are uncomfortable discussing sexual reproductive health issues. They find it challenging to disclose. So there is a disclosure package under the Ministry of Health that supports healthcare workers to work with caregivers to disclose orphan status of teens. And then for the adolescents, mental health issues, we are happy that we have the Common Elements Treatment Approach, CETA, which is a solution, a programmatic response to some of these challenges and addresses other challenges such as substance use, stigma, loss. In schools, there's often stigma and discrimination and a lack of comprehensive sexual education, but we've been working closely with our Ministry of Education colleagues. There's the Comprehensive Sexuality Framework, as well as other initiatives to ensure that the services of adolescents are wrapped around, both at facility and in the community, of which schools are active partners. And then also cognitive development, family, future planning, all those are things that can affect adolescents. Some healthcare providers are uncomfortable discussing SRH issues, and sometimes we bring our own personal values to the discussion. HIV, self-care, comorbidities, We have the advanced care training package, which addresses some of these, as well as prevention of mother-to-child transmission and sexual reproductive health. So I'll hand us over to Dr. Marilwe to take us through poll question 3. Over.
Thank you so much, Dr. Chalilwe. So far, so good. I can see even from the chat box, people are really engaged, and others would do well to also just check at some of the debates that are happening in the chat box. Thank you to Dr. Ziambo, Dr. Hupe, and Dr. Mando for handling the questions there. Also, I must just convey our apologies, dear network. I'm unable to use the video feature because it appears we are overstretching our bandwidth when we do use video. So poll question number 3. With regards to the adolescent HIV care package, which statement is false? With regards to the adolescent HIV care package, which statement is false? Single best answer. A, adolescents are always seen with their caregivers. B, integration of services. C, services are responsive to the needs of both perinatally and behaviorally infected adolescents. Or D, services are empowering by encouraging adolescents to take responsibility for their own health. With regards to the adolescent package, which statement is false? Let's get polling. Which statement is false? Is it A, adolescents are always seen with their caregivers? Or B, is it integration of services? Or is it C, services are responsive to the needs of both perinatally and behaviorally infected individuals or adolescents? Services are empowering by encouraging adolescents to take responsibility for their own health. We have about 15 seconds to go. Okay, so we have just over 60% that have polled. We'll end the poll here and share the results. So the majority think that A is the answer. I'll hand over back to Dr. Chalilwe.
Thank you, Dr. Marilwe. So lots of experience coming through in the polls. That's great, and we'll discuss that later. So what is available as a package of care for adolescents living with HIV in Zambia? So the care of older adolescents is typically directed by adult guidelines. I think, like I said, we find that adolescents are somewhat caught in the middle between children less than 10 in this case, and less than 15, and then adults as well. There is a report that UNAIDS published, which was a big topic of discussion at IAS this year, which was called In Danger. And it just highlights the several risks that we run into if we don't avert the new infections of HIV, of which majority are in adolescents and key populations. So the delivery of adolescent service has an impact on uptake and success as well. So to be effective, adolescent care must be integrated, age and developmentally appropriate. We shouldn't talk to adolescents as if we're talking to adults, but meet them at their point of needs. Services need to be responsive to the needs of both those who've been infected at birth and those who are behaviorally infected. I'm glad that under the community-led monitoring initiative, it sees communities as being drivers of care and not engaged, because as it were before, we were talking about community engagement. So services are empowering by encouraging adolescents to take responsibility for their own health. And this is just not their own health, but having input in the design of their package of care, in the formulation of strategies that address their needs. And the HIV program would not be successful if we didn't retain those who we have in care. And so the retention of adolescents is an issue that really needs to come to the fore. And so we need to have a one-stop shop for adolescents, increasing their ability to access and benefit from services by ensuring that there is integration. Everything is found in one space, the adolescent health-friendly space. Dr. Kakungu, the adolescent health director, is always talking about, having holistic services for adolescents. And I think this cannot be overemphasized. And we need to work at facility level using, all the QI methodologies available to ensure that we improve adolescent services, make them one-stop and get feedback from them as well. So in order to reduce new infections from adolescents who test negative, prevention services need to be scaled up. And so this includes PrEP with all the various new emerging technologies that ensure that we reduce infections, PEP for post-exposure prophylaxis for those who may have been exposed in whatever manner. DREAMS is a service that needs to seamlessly link to facility services. And then voluntary male medical circumcision, condoms for both males and females, and access to information, because we did see that the demographic health survey shows that we have low knowledge levels. So all these things, using a multimodality approach, put together and implemented. I always say, we know the solutions. What lacks is that cohesive integration between all these packages to ensure that we reap the benefits from each of them. So if you say VMMC is 60%, if you say PrEP, if taken correctly, is 90%, all those need to merge to give us a unified package that ensures that we plug the new infections. So over to you, Dr. Malilwe, for poll question 4.
Okay, thank you once again. For question number 4, another scenario question. Terry is a 19-year-old adolescent who is living with HIV from infancy. He is in college and shares a room with 4 other colleagues who are not aware of his HIV status. He tells you that he feels like stopping to take the ARVs because he is afraid of what his friends will think of him once they discover he is taking ARVs. What is the most appropriate action to be taken? And I'm sure a lot of us might have come across this situation. A, should we encourage him to keep hiding his HIV status? B, report him to the college principal for not disclosing his status? C, emphasize personal benefits of taking ARVs such as prolonged life and link him to a support group? Or D, call his mother and inform her son doesn't want to take drugs anymore? Wow, the polls are coming in real fast. This is good. So we'll give it about 10 to 15 more seconds. And I can see this is an engaging topic. So for those, I can see some people have been trying to raise their hands. For those of you that have questions, just either type them in the chat box or wait for the didactic session to be done, and then you can raise your hand and ask your questions or give your comments. So we'll end the poll at this point, and we'll share the results. The overwhelming majority think that C is the answer. So I'll hand over back to Dr. Chalilwe.
Thank you. Like I said, lots of experience translating in the polls, and we hope that the action we've taken is what we need to do. So optimizing treatment effectiveness and supporting adherence. Adolescents have unique needs. They are developmental, physiologic, psychosocial, and so they require comprehensive systems of care. And we also need to be very culturally aware of some of the things that may affect them. And we need to give them differentiated services to look at all their medical and psychosocial needs. Health is holistic. It's just not you give me the drug, but if you don't address all the other issues, the other determinants, you will not achieve your outcome, which in this case is the goals of ART, which just goes beyond viral load suppression, but all those other benefits as well. So to maximize chances of success, it's important that we routinely assess what are those individual factors that these adolescents have, so that they also be involved in treatment decisions that affect their adherence. Like, for example, Terry's situation, it's quite unique. And so we need to, you can't use a one-size-fits-all approach, but really look at what works for Terry. So it involves the caregivers, the client, okay, psychosocial support, and the use of regimen that is simplified, minimal dosing intervals, minimal side effects. So as an attending clinician, you really must balance the goal of prescribing a maximally potent regimen with a client by assessing existing and potential adherence barriers and available youth-friendly support strategies to facilitate adherence. And this is an ongoing discussion. Adherence really needs to be assessed at every visit. If they are on a DSD model, ensure that they are linked to a community group that can assess adherence. So psychosocial support involves multimodal interventions that involve social support, teaching adaptive coping skills to cope with environmental stressors. Life is stressful in general. As adults, we deal with so many stressors, and couple that with hormones that adolescents face. And so it's up to us working with adolescents to ensure that we help them. They have to cope with school, with relationships, with several other issues. All of these things are things I still struggle with myself. So I can imagine, an adolescent who has the extra stress of dealing with their HIV situation as well. So strategies that improve their outcomes include provider education, integrating trauma-informed care practices like CETA, increasing access to mental health professionals through co-located services, expanding care delivery paradigms such as telemedicine, and optimizing treatment approaches, like we're doing right now. If we can utilize that in the care of clients, that would be good. So let's say you use 70-40 to consult on a patient, or you set up a Zoom call to discuss a client or to facilitate counseling. All those are strategies that we can undertake to ensure that we meet the unique needs of adolescents. So like we said, we advocate for simple regimens, fixed dose once daily, with high barriers to resistance if possible, and minimal side effects. And then the plan needs to be developed in partnership with the adolescent, considering their daily schedule. So for example, if you have an adolescent who won't have privacy in the morning, you can shift their pill taking time to a more convenient time. Look at the pill number, size, and frequency, issues affecting absorption, potential adverse effects, because if we don't cancel them for these, when they emerge, they can actually threaten adherence. And then also reminder systems, lots of apps nowadays, cell phone reminders, pill boxes, buddy systems. We discussed the possibility of having peer support even in a boarding school. All those are strategies that need to be employed. Also emphasizing benefits of viral suppression, improved health, the U is equal to U, undetectable, lineage untransmittable, status disclosure to sexual partners without HIV may act as a particularly strong motivator for reducing stigma and improving adherence among adolescents with HIV. So clinicians should consider simplifying regimens using ARVs with high barriers, like, for example, the integrase strand transfer inhibitors, and using regimens without drug resistance. I remember we did say that, especially for those who are perinatally infected, some of them have complex treatment histories, have taken several regimens. And so, as we will look at the case, very interesting case coming ahead, we will see how emerging evidence actually makes our lives even easier. So the integrase strand transfer inhibitors, dolutegravir, which is the one we have here, widely available, offers a once daily dosing. When it's combined with a dual nucleoside backbone, it also, you take one tablet a day, high genetic barrier to resistance with very good side effect profile and tolerability with good adherence. Also, the drug-to-drug interactions with like co-infections are minimal compared to other regimens, and so the dose reductions are less. So for those who are ART experienced, like I said, those who acquire early, they may have extensive resistance, complex regimens, and adverse effects. So DTG is safe and well tolerated, achieving viral load suppression rates of 44-60% when combined with an optimized background regimen, and DRV can be used as well. Additional considerations include the risk of side effects such as bone and renal toxicity with TDF-based regimens in rapidly growing adolescents. That's why we have that age caveat, and also concerns on magnified in low weight adolescents, those who start ART with a low weight, for whom we might not have formulations for them. And also, because adolescents haven't reached their peak in terms of bone density, TAF is preferred instead of TDF. So if we can have TAF, 3TC-DTG, that's a preferable option for adolescents. So we talked about transitioning care. So we talked about adolescent-friendly spaces, but you really can't keep an adolescent in the same space for a long time, because they need to develop socially, develop more responsibility for their self-care, self-advocacy, and it may be challenging for the adolescents depending on their level of development and maturation. And not all adolescents may be ready to make the transfer to adult care at the same age. And it's really, we looked at assessing individual factors. And so it really needs to take into account their developmental level and meeting them at that point where they're at. And healthcare workers must take into account their cognitive and physical development. So for example, you might have an adolescent who's 18 years old in terms of their chronological age, but their cognitive age may be way lower, because especially those who initiate ART late, as we know, HIV is a neurotropic virus, so they may have suffered HIV encephalopathy, which may have them have delayed milestones. So all that is important in the assessment of the adolescents, for you to assess them holistically. And so there's also the issue of their emotional maturity. What support do they have at home, in the community, and their health status? And all those factors need to be considered in terms of transitioning them to adult care. Dr. Muya and team, ESNAT, Dr. Jinwala, Dr. Thomas will tell you about several episodes when adolescents, come back to complaining of how maybe their transition was too rapid. And so that's why it's important that it's a process that involves the receiving side as well as the sending side, and involves the adolescents as well, so that it's a seamless process that takes into account all their individual needs. So it is possible to have a smooth transition to adult care and receive adolescent-friendly services in the adult clinic. And some of the elements taken into account is an agreed transition plan that gives the adolescent time to prepare. So it said, oh, at such and such a time, we will need to start discussing you transitioning, so that they process these emotions and introduce them to the other side in a continuous manner rather than an abrupt manner. and an adult clinic that is willing to meet the special needs of adolescents and is staffed with healthcare workers who understand the special needs of adolescents. You know, it can be quite sudden and disruptive to them to just go to the adult clinic, meet adults who are unsupportive. It can have an impact on their care. And so some strategies for smooth transitioning, including identifying adult providers who can provide these services in a youth-friendly manner, having a formal, purposeful, individualized transition plan that addresses all their needs, including their medical, their psychosocial, who is their primary caregiver, if at all, how would that transition be, who will be, you know, overseeing this transition from the caregiver side, and their financial aspects as well, which is why you've heard me more than once during this session talk about how support community services should be closely linked to treatment services, having wraparound services for adolescents to ensure their unique issues are addressed. And then including us just talking to each other. The adolescent clinic, the adult clinic talking to each other, having a plan, how many are they expecting, who's coming, what are their unique needs, looking at adherence issues, virological failure, and resistance as well. So this is a dream site. As you can see, you have adolescent girls meeting, you know, discussing several issues, not just to deal with sexuality, HIV, but also economic empowerment issues and just positive dignity and prevention as well. So, Dr. Mwalilwe, over to you for the final poll question of the day.
All right, thank you so much. So the fifth and final poll question: the following are programs used for the management of adolescents and young people living with HIV. Is it A, peer-to-peer support, B, adolescent-friendly health services, C, community-based interventions, for example, community-based adolescent treatment supporters, CATS for short, or is it all the above? We have about 30 seconds to poll. Only 4 people. The following are programs. Just launch the poll again. The following are programs used for management of adolescents and young people living with HIV. Is it A, peer-to-peer support, B, adolescent-friendly health services, C, CATS, or D, or the above? Ten seconds. We'll end the poll here and share the results. Okay, the overwhelming majority think that D is the answer. Dr. Chalilwe, over to you. Dr. Chalilwe, I think you are muted.
Thanks. Apologies for that. So I was saying that people are so confident that they're posting the letters in the chat. That's a good sign. So UNICEF reported that the most commonly implemented program for adolescents were peer-based support, followed by adolescent-friendly health services, community-based interventions, social protection and economic strengthening, as well as youth-led advocacy and engagement. And you can see how you know, on the diagram on the left, how that all these different interventions, these different program areas create wraparound services that protect the gains and prevent new infections as well. So because it looks at adolescents as you know, holistic individuals that have all these needs, including social protection and economic strengthening, which is a big concern for most adolescents, in addition to the other issues. So our key summary points for today is that adolescents and young people who are living with HIV could have gotten their HIV from their mothers, or during adolescence or before adolescence through sexual abuse. And we really need to ensure that the drugs that they are taking are optimized to reduce morbidity, mortality, and transmission. And those who are living with HIV are at risk for poor outcomes. It's important to assess behavioral and psychosocial context and the ability to affect adherence. I think we've been discussing this throughout the whole session. This cannot be overemphasized. They need youth-friendly services. I know a lot of times this issue is discussed, infrastructure pops up a lot. There are alternatives like tents. We need to reduce barriers to adherence. It's possible for them to have a smooth transition to adult care, receive adolescent-friendly services in the adult clinic. We need to prepare them to take on more responsibilities. And also, as healthcare workers, should be aware that they're just not your clients, but they've got many challenges, unique needs, and we should be able to meet them at their points of need. So those are some of the references for the presentation. I'd like to thank Dr. Manzi, Dr. Ziambo, who were instrumental also in the setting up of this presentation. I'll hand over to you, moderator, to moderate the interim Q&A. Thank you.
Okay, thank you so much, Dr. Chalilwe, for the presentation. It was a very good presentation. I know the slides are packed, but you really delivered the content in good time. So we'll just spend about 3 minutes just to repo, and then after that, we can have a discussion. IT, we can launch the poll questions so that we just have a small discussion around them. Okay, so the first poll question has been launched. We can repo. Okay, question number 1. So this should be real quick. 10-year-old Mapenzi presented to the health facility with multi-dermatomal herpes zoster on his back. An HIV test done, comes out positive. His mother died 8 years ago. The following are possibilities of how he could have most likely acquired HIV, except this is a single best answer. At birth, breastfeeding, sexual activities, or scarification marks made on his body by his grandmother for chronic diarrhea. Let's poll. Okay, Dr. Chalilwe, as you can see, the first question seems to be pulling people in different directions. Kindly take us through this question. Thank you.
Yeah, I mean, I don't like these questions that say accept and whatnot. So essentially, if I was to rephrase the question, I would say that all of these can result in Manzi having contracted HIV, except which one? And there's the caveat that says most likely. So most likely 8-year-old Manzi could have gotten HIV from his mother, like maybe before breastfeeding, could have gotten it through breastfeeding, could have gotten it through scarification marks. So the most unlikely is sexual activity. Not impossible. A small child can get HIV through child abuse, but when you look at the options here for an 8-year-old, the one which is less likely is sexual activity.
Thank you for that one. So for those that could still be confused, you can still post in the chat box. I saw that there was a debate going on, and people managed, some experts came through and explained some things. We can launch the second poll question. Second poll question: the following factors put adolescent females at risk of acquiring HIV, except this is also a single choice answer. The following factors put adolescent females at risk of acquiring HIV, except insufficient thickness of vaginal wall, insufficient mucus protection, they do not know how to clean their genital area properly, or D, cervical cells, which are protective against infection, are not yet fully developed. We have about 10 seconds. Okay, we end the poll here and we'll share the results. So, Dr. Charlie, for this one, the majority, 81% of the people that vote, that's just about half of the network, they think that C is the answer. But there's a significant portion that think the others are the answers. Please take us through this one.
Yeah, and this is surprising because initially, before the discussion, most of the people picked C. So again, except, so which factors will lead to adolescents contracting HIV? We did say that their vaginal walls are not fully developed. We did say that there's insufficient mucus protection, as well as the cervical cells, the epithelium is not well developed. So it's not an issue of cleaning. In fact, vaginal douching is not encouraged. It's more the biological factors in this regard that predispose adolescent girls to contracting HIV due to biological factors. So the answer is C.
Okay, thank you so much for that one. We'll launch the third poll question. All right. The third poll question. It's okay. With regards to the adolescent package, which statement is false? Adolescents are always seen with their caregivers. Integration of services. Services are responsive to the needs of both perinatally and behaviorally infected adolescents, or services are empowering by encouraging adolescents to take responsibility for their own health. So let's quickly poll. Okay, we'll end the poll here and discuss.
Okay.
So from the results, you can see that I think the majority think that A is the answer. So yes, the majority think that A is the answer, with a few people thinking that any of the other options were the answers.
Yeah, so we did discuss the need to integrate services, have a one-stop shop. Our services need to meet the needs of both types of adolescents, those who acquired HIV from their parents, those that acquired behaviorally, also services empowering adolescents, encouraging them. We did discuss that as well, to take responsibility for their own health. So we know that it's not true. That's why I said there's a lot of experience coming through. We know that they're not always seen with their caregivers. And there are some who it's concerning. You hear the team saying, oh, this adolescent always, almost never comes with a caregiver. So the answer there is A, because that it's not always true that they're always seen with their caregivers. Over.
Thank you. We will launch for question 4. So for question number 4 is a scenario. I'll start reading the scenario as we launch it. So Terry is a 19-year-old adolescent who is living with HIV from infancy. He is in college and shares a room with 4 other colleagues who are not aware of his HIV status. He tells you that he feels like stopping to take the ARVs because he is afraid of what his friends will think of him once they discover he is taking ARVs. What is the most appropriate action to be taken? Encourage him to keep hiding his status? Report him to the college principal for not disclosing his status? Emphasize personal benefits of taking ARVs, such as prolonged life, and link him to a support group, or call his mother and inform her that her son does not want to take drugs anymore? Very interesting scenario. Many of us could have come across it. We'll end the poll here, and Dr. Charlie will take us through the answer.
Thank you, Dr. Malilwe. So last week, I met up with some colleagues from CIDAS, and there was a case of an adolescent who, whenever they go on holiday, they default their drugs. So when the mother sends them to the grandmother, to the uncle, they stop treatment. And it's a very complicated discussion, because the mother says, look, I can't keep disclosing my child's status everywhere. Do you stop this child from going on holiday? So really, this type of scenario is a very real one. And so what seems most feasible is, of course, you can't encourage him to keep hiding his HIV status. That requires discussion. You can't report him for not disclosing. And the most reasonable solution is to emphasize the personal benefits of taking ARVs, and also link to a support group. And we've been having discussions about, boarding schools, working through. The Ministry of Education has identified career guidance teachers or any other person on staff who's been trained in HIV services, who can act as support for children, for adolescents that are in boarding schools, so that we avoid things like this. And so it's incumbent upon that carer, who is a proxy parent, to then develop all these unique strategies to support this adolescent to continue taking treatment. Over.
Thank you, Dr. Chaliwe. So the last poll question will be launched just now, the 5th poll question. The following are programs used for management of adolescents and young people living with HIV: peer-to-peer support, adolescent-friendly health services, CATS, or the above. Just give us just a few moments to share. So this four, we seem to be having challenges, launching it. So Dr. Chalilwe, are you able to just take us through? Dr. Chalilwe, you're muted.
Are you able to see my screen? No.
Yet. Okay.
So we were looking at which programs are used in the management of adolescents and young people living with HIV, and we talked about peer-to-peer support. We did describe how UNICEF had picked those services, adolescent-friendly services. We need to be, friendly, not the way you guys are looking at Mukinge College. There are people looking serious in the front. When you're dealing with adolescents, you need to have a very lively approach. I'm looking at Chipata Central, the way we're seated in the front there, laybacks. We need to engage the adolescents so that we make them feel comfortable. So community-based interventions, there's the CATS model, community adherence treatment support. This is was common in the Zvandiri model in Zimbabwe. So all of these, and then in Zambia, we have, interventions such as the Project Yes from Arthur Davidson's. All those are strategies that can encourage or promote adolescent-friendly space services. So all of the above are correct.
Thank you, Dr. Chalilwe. This was a very powerful didactic session. And indeed, we have even gone over time. We just have about 23 minutes left. So I'll ask Chadiza team to quickly share their case and go through the case in about 10 minutes so that we can have about 5 to 10 minutes just to discuss around the didactic presentation as well as the case. Chadiza, are you ready to share your case? Okay, so Dr. Mando there has shared the case. Ruth Gondwe, you can probably go ahead, unmute and present your case.
Yes.
Good afternoon, everyone. Are you able to hear me?
Good afternoon. Yes, we can hear you.
Okay. So my name is Ruth Gondwe, clinical officer from Chadiza District Hospital. This is our case presentation. Okay, so this is AM, female, 16 years old, currently schooling in grade 5. Child was tested HIV positive on 27 September 2011 at the age of 7 years and was enrolled on standard treatments at the time on 31st October 2011. The recipients of care was a transient with a high VA of 20,498 in 2018 and was put on TLE at the age of 12 and started on EAC. At trans-in, the recipients of care was not disclosed to and would be left unsupervised as parents went for farming. So the child would skip her lopinavir dose due to the lack of supervision. Food disclosure was done at 15 years old, according to the family. So this is the firstborn child in the family of 3, whose 2 siblings. This is the firstborn child in the family of 3, whose 2 siblings, the 8-year-old boy and the 3-year-old girl, were tested HIV negative. So both parents are HIV positive on ART and both are alive and farmers. There is no history of TB, asthma, sickle cell, or malnutrition in the family. On physical examination, this is the recent, on the 4th August 2022. So the general condition of the client was stable. There was no fever, no jaundice, no cyanosis, and no pallor. The child was well nourished. Respiratory system was clear. Cardiovascular system S1 and S2 were normal. The weight was 35.5 kg and the height was 135 centimeters. Sorry, I forgot to put the BMI, but the BMI was 16.9. Next slide. Okay, so this is just a profile of the tests that were done. So the time the child came in 2018, that was in March, the CD4 count was 551, AST was 27.2, creatinine 36.7, the HB was 7.4, and the viral load was 20,498. By that time, the child was on CLE. Then on 28th November 2018, the only results that were done were viral loads. So the child has 713,000 copies. And then the child was put on ABC, 3TC, and Lopinava. Then on 26th March 2020, the VL was 17,000, and the regime was ABC, 3TC, and Lopinava. Then 10th December 2020, the child's 10th December 2020, the VL was 14,900. By that time, the child was switched to Tafid. Then on 15th March 2021, the viral load was 92,300, and the child was later put on second line. Then on 9th September 2021, the viral load dropped to 9,940. The child was still on second line, SAT, 3TC, and Lopinava. Then 13th December 2021, the VL was 50,000. It went up again. It was 50,900. The child was again switched to ABC, 3TC, and DTG. Then on 12 April 2022, the child was tested again for VL. It was 49,100, and the child was again put back on Tafid. Then the recent results, that was last month, 19th July 2022, the child's VL was 35 and was put on DTG, 3TC, and TDF. Yeah, so our questions, like the first question is, at what age should we consider starting the disclosure process in children living with HIV? The second question, what is the role of the healthcare worker in the disclosure process? And the last question, how does the lack of disclosure lead to high VL as seen in our clients, and how we can prevent such occurrence among adolescents? Thank you.
Thank you so much, Ruth. That was crystal clear. You were composed and you were very clear in your presentation. So thank you so much. I can see your questions are centering around disclosure. I'll just try and summarize the case. This is a case of a female 16 who's been on treatment for about 9 years. Okay, but disclosure was only done a year ago. This is a recipient of care that came in with a high VL and has been managed with different regimens, some second line, back to first line, second line, first line, and the like. But currently, the adolescent is actually suppressed. So we can go, just take us to the questions once again. I'm sure there are people that would like to find out a few things about this case. So if you have any queries, you can raise your hand, we'll spot you and we'll give you a chance to speak. Or indeed, you can type in the chat box. So the team in Chadiza is asking, at what age should we consider starting disclosure process in children living with HIV, considering that in this case, this disclosure was only done when the child was 15 years old. And they're asking if there's a role of the healthcare worker in this disclosure process. And thirdly, does lack of disclosure lead to high VL as seen in our client? And how can we prevent such occurrences among adolescents? So network, if you are not clear, you can raise your hand, then we'll spot you and we'll give you a chance to speak. So in the chat box, Rachel Thomas is asking, is there any latest CD4 or creatinine results? Then Mfune Frank is asking, why was the child switched back to first line? In other words, what was the rationale for switching the child back to, to first line? So I think Muguni is also asking around the same, what criteria were you using from first to second line and back to first line? So Ruth, are you, or the Chadiza team, are you able to take some of those questions?
Yes, please.
Yes, please. So please go ahead.
The genotype was done. But for the criteria to switching the child back, it was in consultation, like it was done after consultation from the province.
You mean the genotype came back and said the child could still be put on first line and it was still okay?
Yes,
So
the
maybe,
genotype came back and it was still okay.
Okay.
yeah, so maybe I can help Chadiza pick up some questions.
Okay, yes.
Yeah, so just some background about this story is about this particular client. So this is one of the last clients that was unsuppressed at this particular site. So Chadiza District Hospital is one of our shining stars in Eastern Province that has currently all the children that are in the car suppressed. And I think I picked on this particular case because they had a couple of challenges addressing this particular client on what needs to be done. So yes, a genotype was done at that particular time, and switched to a first line regimen to try and simplify the regimen for our client. And before we could get back our genotype sample, what genotype result? What returned was the suppressed viral load of 35. So you know that with a suppressed viral load, definitely your genotype will actually not be run. So it was not been processed. Yeah. So far, EM is doing well on medication, and we are happy that she's now much better. I know the story comes out like she's now suppressed. Okay, so what are we learning here? We are also trying to demonstrate that after she only suppressed after the disclosure was done, after she got adequate counseling, and now she was able to take this medication consistently, correctly, and now she's on a better regimen that allows her just to take this medication once per day due to some guidance that has been shared. Thank you.
Thank you so much for that. You can possibly address some of the questions in the chat box as well. Dr. Collins is asking about adherence issues, if these were addressed before the switches were made. D. Kamalondo, you have your hand raised. D. Kamalondo, you can go ahead and unmute.
Okay. Yes, Doc. My question is that If you look at the way they transition this patient to the second line, did they do EAC or they just rush to transition the patient? Because it looks like it was just poor adherence that was causing this child not to be suppressed. What criteria did they use? Just like the way other people are asking, why did they rush to switch the child to second line instead of trying to find out if there was adherence or not? Thank you.
Thank you so much. I think that question has been taken note of. Charles Meeting. Charles?
Yes, please. I picked on the BMI, which was 16, if I'm not mistaken, because it wasn't written there, so it was just mentioned. 16, I'm concerned. Can we also look into the nutritional status of this client? Because I know that she's suppressed, but also the BMI is low, it's 16. Can we also address the nutritional status of the client, please?
Thank you so much. The Kiembes, Ndola.
Thank you, Chair. The disclosure process can start as early as 6 years, putting into consideration the developmental stage of this child, as well as the cognitive ability of this very child. Then the role of the healthcare worker in this case would be just to give information to caregivers, as well as guide them on how best they can disclose the status to their child. Then on the third question, what led to this one was maybe preparation of this very child in knowing and understanding the HIV status possible. So if the preparation was done on time and also timely disclosure, this could have not led to high viral load in this case. That is my submission. Thank you.
Okay, thank you for the submission so far. So I'll ask that because of constraints of time, we are obviously unable to discuss this case in detail. I'd ask that even as we ask the questions, what do you think we would have done better as Chadiza team? You know, when you talk about nutrition, when you talk about all these switches in drugs, how do you think we can best help Chadiza team to be able to do better next time? While we are tackling those questions that we are asking and providing solutions, can we also look at some of their questions and answer them, considering that we only have about, less than 8 minutes to go before it's time up? I like the approach that Rachel has taken in the chat box, offering solutions. We need to be able to monitor closely, especially the viral load, because of what is, the recipient of care had DTG in 2020 and the like. So can we begin to probably attempt some of these questions that our friends have? Lena Mulelema, you can unmute. Hello, there's a lot of feedback where you are. Dr. Kanda, are you able to unmute? I can see you were saying we unmute you. So Mbewe HNP says disclosure starts from 5 to 7 years. Hello, Dr. Kanda?
Yes.
You,
can get
yeah,
me
you
now.
sound a bit distant. I can get you.
Yes.
Please go ahead.
We had a problem with this child. This is the case we received from Chenga Hospital. The child came first with high viral load. So what we did, we started first conducting ESGs in the same child. And during the ESGs, we discovered that disclosure was not done by the mother, despite the confirmation that they did disclosure. So after the full completion of the ESCs, the child remained again with high value. We try now to dig deeper to find out what is really the main causes of this positive high value load from the child. We discovered that what the mother said that they did disclosure, it was not true, it was wrong, it was not that. And secondly, there was poor adherence from the child. It was not taking correctly the treatment as it was prescribed. From the ABC 3TC lopinavir, which was given, the child was getting only ABC 3TC without lopinavir. The time she came now for the second
Kanda, you.
We told them to come with the bottles, and the most discovered lopinavir was missing. She was not taking that one. So to make things easier for the child, we switched the child from ABC 3TC to TAFID to make it simple for the child to start taking it, which was not which didn't sort out the issue completely. The following session, the child came back and we didn't find any one of us, and he was put on second line. And after discovering that it was put on second line, we instructed again to put the child on the first line as it was supposed to be. This one was after consultation with the provincial team, specifically Dr. Mando. So the time now the child was returned back to first line, we tried to emphasize on adherence issues. We developed a system which is similar with a DOT system, where the mother was instructed to give on her own medicine to the child. And every time she was giving, she's supposed to tick and bring us the evidence of giving the drug, which was done. And after the third session, we tried to reassess again the child vitally. And unfortunately, the result came suppressed. So this is the holistic story of this child. On our side, we can say that there was mismanagement truly, but the guidance came, which was followed up, and the result we have seen that the VO was suppressed. What you saw there, it is the only result which we have, because I saw some questions concerning creatinine, CD4. What was done is what we have exposed. So in summary, this is what we have done for the same child. For assessing the nutritional status, this hospital has got a nutritionist who is currently looking after the same child. So this is just to share with you that the nutritional status is not left out. We are looking at it as now. So in summary, this is what I can share with you, the story of the same child. And thank you again for your kindness. Thank you. Over to you, Doc.
Thank you so much, Doc. And that was elaborate about the case. So at this point, I think I'll just allow some of the experts to share their knowledge with us, just in conclusion of this case and of this echo session. But I'll highlight the points that Ailes Mbewe has said in the chat box. She says disclosure starts from about 5 to 7 years, which is early disclosure. And we have partial disclosure about 8 to 11 years. And 11 to 14 years is the time that you do full disclosure. So as caregivers, we should take note of the stages and the process. At this point, Esnat, are you on the call to just give some remarks as one of our experts? Okay, it appears Esnat is not on the call. Rachel Thomas. Okay, Dr. Ziambo.
All right, thank you very much. I like this case because it highlights all the issues that we've been trying to discuss in this particular didactic session. And I just want to point out to our network that you see that this child probably is in the class of those that may have acquired this infection from EMTCT. From the time that perinatally, antenatally, and that process. So this is a child who qualifies in those who have had several regimen change. And so as you receive this kind of a patient, you have to have all those considerations as you are reviewing this particular adolescent. And then apart from those issues, then you also have all these social factors. Who has he been growing up with? Who has been taking care of him? And you also see that there's been a disclosure issue here. He has not had the social support he needed, and so has really strayed off in terms of taking therapy. And then you look at the choice of drugs that perhaps the child may have received. He had SZT, 3TC. Those are not the simplified options. But as we discussed in this particular didactic today, we're looking for simplified options as we choose the drugs that we want to give. We want to make sure that we just give a one tablet, if possible, at least 2 tablets once a day. It also helps with adherence and all that support. And so we see that the Chadiza team and Eastern Province team really worked very well, collected the viral load, collected the genotype, and really supported this child through. So it's a multidisciplinary approach in terms of care, and everybody needs to put in, and we just need to be aware of all the events that can potentially affect our adolescents and young people for us to be able to optimally provide them a good comprehensive service. So in summary, I just thought that you just highlight that, and I hope we picked out 1 or 2 things from that. Thank you so much.
Thank you, Dr. Kozia. Dr. Chalilwe, you are on the floor now. Give us your closing remarks.
Yeah, thank you very much. Great case, great discussion. Thanks to Ruth, Dr. Kanda, Dr. Mando for the management of this client. And just to say that the disclosure process is stated in the guidelines. So, it can be caregiver initiated, healthcare worker assisted, and adolescent initiated, and all that is available in the HIV guidelines. But also just to underscore the importance of using a problem-based diagnostic model when you have a client in front of you. What do I mean by that? I noticed that all of us sort of rushed to the teething questions of what was this test, what was that? But like Dr. Ziambo said, there was adherence factors, there was disclosure factors, there was social factors. There's also mental factors that never came out, in like the management of such a child. And when you address each of those needs, it will help to address the needs of our client holistically, including referral to dream services and all that. This case clearly highlights poor adherence because once the child was transitioned to DTG, we expected a very rapid drop in the viral load. But you find even 6 months after that, there was still a high viral load, which shows adherence. Yes, there were concerns about probably a resistant dual backbone, but there's been studies such as the Vicent study, which has shown that even with some resistance in the backbone, a regimen that contains DTG will actually suppress clients. And so the fact that this client did not suppress, just like I think in the chat box, it was there, adherence. So again, to recap, problem-based diagnostic model, list all the problems affecting the client, all the dimensions and domains, social, disclosure issues, medical diagnosis, then all your malnutrition, all your comorbidities fall into place, adherence, then you look at all these different factors under adherence. Is it cognitive? Is it behavioral? Is it socioeconomic? Is it emotional? Then finally, there was a very good, there was an interesting discussion in the chat about drug-to-drug interactions. And I know this is probably not the fora, but interestingly, in an advanced disease session, we're talking about interaction of hormones and regimens. So like Dr. Jambo said, if you have a complex case where you have maybe a transgender client who's on hormone replacement therapy, see that you refer them, but be rest assured that most of our first-line regimens have no significant drug interactions with replacement hormone therapy. Either they're on, testosterone, estrogen, or androgen blocking drugs. So you can safely continue them on the DTG-based regimens. And most of the interactions are with the older regimens that we used to use, in which case there's monitoring. So you can just optimize their regimen in terms of optimize their adherence, and of course, make the necessary consultations as well. So in adolescents, think adherence, 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 and address each of the domains of their diagnosis for holistic care. Thank you very much. It's been very interesting being with you, and over to you, Dr. Madiba.
Thank you so much for the presentation, Dr. Chalilwe, for your expert knowledge and for spending time with us this afternoon. Thank you to Dr. Kozia. Thank you to the other experts, Dr. Mando, who was very active in the chat, Dr. Wupe, very active in the chat. So thank you so much. I know there could be so many questions around this topic because it's really something that we're dealing with every day, and we'd like to know more. I know time cannot allow for us to go on, but I just want to say thank you to the network for being with us. I'll just call on Etambuyu if we have any announcements. It appears we may not have any announcements. So at this point in time, the time is 4:07. So sorry for overshooting just a little bit, but thank you for your participation, dear network, and we will continue to interact and to share knowledge. So thank you again for attending from us at the UTH Hub. It's bye-bye for now. Thank you.